Good evening, everybody, and Dr. Worsley as well. Thank you for this opportunity to be able to talk a little bit about the COVID-19 vaccine. As you know, things are moving fast and furious. However, the way I like to frame this is finally, the light at the end of the tunnel is arriving. It's growing brighter by the day. Still not that bright light yet. It will get here. So I just want to begin by saying yes, we as public health have been at this battle, I would say, since mid February or early March of last year, and the picture on the screen there of me was taken in April of last year during kind of the early stages of this pandemic craziness, which quite frankly seems like a lifetime ago. Um, so a year of this, I'd say, has brought a lot of wisdom, but it's also made me look a lot more like Yoda from Star Wars. So I might not actually match that picture anymore. I'm going to hide behind the PowerPoint slides if you don't mind as well. So this is kind of a list of the topics that I'd like to cover tonight. More or less kind of give you a big picture with regard to how vaccines fit into the overall prevention landscape, then talk about the vaccines themselves, the state plan for rolling out the vaccines, and kind of a little bit of a heads up as far as what's next, both for individuals who actually receive the vaccine, as well as what we're kind of looking for in terms of when some of this might end. All right, so this is that big uh, picture that I wanted to share, and I wanted, and I think it's very fair to equate the the battling of this pandemic and calling it really the largest public health operation in U.S. history. Comparing it to gearing up for and fighting a major war would be pretty much what public health has been doing. So we've gone through some major battles already, which include figuring out what this virus is. Remember, it was just a little bit more than a year ago, late December of 2019, when we first heard about this strange virus in Wuhan, China. Next thing, we moved on to putting up the first lines of defense like social distancing, testing, and containment, which is the contact tracing and case investigation side of things. And so again, now we're finally able to offer the stuff that will bring this thing to an end, the vaccine. So the point of this slide is really to show you that vaccinations are but one part of a larger prevention operation. So much of these things listed here will need to continue until we get enough people vaccinated and until we learn more about the longer term effectiveness of the vaccine. So let's just talk a little bit about vaccines in general and then the COVID vaccine more specifically. So vaccines have done an incredible job in protecting life. They've been probably one of the biggest major medical breakthroughs. And in terms of public health, next to safe food and clean water, they've contributed the most to extending the human lifespan. So one type up in the top left corner are what are called the genetic vaccines that are candidates or more than candidates. I'll get to that in a moment. What they do is they introduce the genetic material called RNA or DNA into your cells that basically tell your cells to start putting out a protein normally found on the outside of the COVID virus. So when your body senses that viral protein, it activates an immune response. It prepares your body in the event you actually get infected with the COVID virus. So some of the companies that are using this technology include the two that have produced vaccines so far. So these include the Pfizer vaccine as well as the Moderna vaccine. These are genetic code vaccines. So the next type of technology is the viral vector vaccines. You'll see those on the top right of your screen. So they use basically a different virus that's inactivated to serve as kind of a Trojan horse to deliver a bit of the coronavirus genetic material into your body. which your immune system learns to then identify and overcome, again, producing that priming mechanism in the event that it see that DNA later on. So this includes the AstraZeneca vaccine, which is potentially due out fairly soon. The next technology are the subunit vaccines, which you'll find in the lower left corner. And these are more traditional types of vaccines, basically literally grind up a virus and inject fragments that your body then stimulates an immune response to. And then finally, in the top lower corner, right corner, are weakened or inactivated vaccines. There have been many vaccines that have been developed this way. So this uses the virus itself, however, they've been weakened or killed such that they actually cannot cause disease. Again, using the same overall approach. It triggers your body to create an immune response. Now, the one thing I do want to stress that all of these methods ultimately lead to protection, but they do not give you the COVID disease. So I want to take a little bit of time to talk about how vaccine trials work and how the overall process that led to the development of the COVID-19 vaccine followed basically the essential steps of what it takes to generate a vaccine through kind of normal traditional means. However, they were sped up, but no corners were cut. So these are two timelines. The top one is the traditional development timeline, and the bottom one is the timeline for the COVID-19 vaccine. So if you look at the timeline, again, regular vaccine development from scratch can take about a decade or more to get us a vaccine. And that's following all those steps in sequence. Now, if you compare that to the bottom timeline, which shows COVID vaccine development, it was accelerated in the following ways. So first of all, there was a lot of background science already available from studying other diseases caused by other types of coronaviruses. And this includes the SARS COVID virus, as well as the MERS COVID virus. Those are alphabet soups, but those viruses have been around. Vaccines have been developed for both of those types of viruses. So the overall time frame, if you look towards kind of the middle of that bottom timeline, for the clinical trials was reduced because the time frames for the individual phases were overlapped. And these phases include a phase for establishing the safety of the vaccine, the efficacy or effectiveness of the vaccine, and then finally, you'll see they're listed as phase 3, but a combination of looking at both safety and effectiveness together. So some of these phases were overlapped. However, they were done in a very robust manner, in many ways, increasing the sample size of individuals who were tested to, again, get incredibly good data. The final huge difference was that vaccine production was started while the clinical trials were going on. So companies could essentially take on the risk of producing vaccine even before they passed all the necessary safety and effectiveness trials because the government covered their costs even if their vaccine failed. So what this meant was that a stockpile of vaccine could be built up, and when a vaccine candidate made it through all the necessary regulatory steps, got the green light from the government as far as its safety and effectiveness, it could be made available to the public immediately. And that's what happened. We started getting vaccine available, 4 weeks ago. So vaccine candidates, final step, go through federal review before being released to the public for use. Let's talk a little bit more about safety and effectiveness of the COVID vaccines that we currently have available. This would include the Moderna vaccine and the Pfizer vaccine. So when we talk about efficacy or effectiveness, we're essentially talking about how much the vaccine protects the people who get it compared to those who don't. So you'll see there on the slide that both the Pfizer and Moderna vaccines show around 95% efficacy or effectiveness, which, gotta say, is incredible. To put this in comparison with flu vaccine, and again, there's typically a new flu vaccine offered every year to kind of keep up with flu virus mutations. The efficacy of flu vaccine is, on a good year, around 45 to 55%. So this is a really, really impressive level of protection that these vaccines offer. So with respect to safety, I spoke a little bit about the testing, considerable testing that had been done in the clinical trials, as well as that step that the federal government must take before releasing it to the public. And what they did is they used what's called an emergency use authorization process administered by the FDA, which again looked at data generated by the trials and then more or less fast-track use by offering this emergency use authorization. Now, I got to say that safety and efficacy will be continually monitored as we move into dispensing this vaccine broadly through what is ultimately phase 4 safety and efficacy trial. So folks will be continuing to look at, again, how safe and effective this vaccine is as it's being dispensed. All right, this looks like a crazy roller coaster. I am not going to spend a whole lot of time on this, but this is just for individuals who are very, very interested in information and very interested in timelines. So you can find this on the VDH website. And perhaps if this presentation, I believe it will be made available later. So this is the timeline describing vaccine development overlapping key events in the Virginia and national response by date, just to kind of give you a sense of what all has happened since, gosh, way back last November. So let's shift gears and talk a little bit more about the vaccine itself. So again, there are currently 2 vaccines available, and for each of those vaccines, anyone who gets them needs 2 doses. So for the Pfizer vaccine, which was principally offered to hospital systems to vaccinate their own healthcare personnel, you need 2 doses 21 days apart. For the Moderna vaccine, which is becoming more readily available to the general public, and this is the vaccine that we're able to dispense now following the phases, which I'll describe later, you need 2 doses 28 days apart. Now, it's critical that you end up with the same vaccine that you started with. So you must get the same type of vaccine for both of those doses. The most common side effects include injection site pain for a day or so, as well as fatigue. So I got my first shot last week and had mild pain at the injection site, my arm, for about 24 hours. I'm completely fine now. And so there's been a lot of reported data that it's primarily those 2 things that are relatively mild. So who can get the currently available vaccines? So with respect to age, there wasn't a whole lot of data collected on children and adolescents. So the vaccines that are currently available are not yet authorized for individuals outside of the age ranges listed above. So for the Pfizer vaccine, it's okay for individuals over 16 years old or over. For Moderna, that's true of individuals 18 years old or older. It's okay to get either of these vaccines if an individual is pregnant or lactating. And there are very, very few medical reasons to prevent a person from getting it. If you do have medical concerns, it's best to, I think, always best to contact your physician or healthcare provider. So who should not get the current vaccines? So the medical term for this is contradictions to receiving a dose. All right, so apologies first. I know there's a lot of information on this slide, but I want to focus on a small portion of it, which is the allergy portion, which is roughly in the middle of those 3 blocks that are green, yellow, and red. Now, again, this applies to the Moderna and Pfizer vaccines that are currently available. When we get to new vaccines, there will be different guidance for each of them. So if you look at the allergy portion, again, roughly in the middle, in the green section, this is for individuals who can go ahead and get vaccinated. You can get either of these vaccines, even if you have allergies to oral medications, have a history of food, pet, insect. Let's see what it says here. That's tiny print for me, or environmental allergens, and even a family history of allergies. So green means go, even if you have those allergic conditions. If you look in the allergy section in the yellow, this is where you need to sort of slow down as far as moving forward with getting the vaccine. You should consult a medical professional if you have a history of immediate allergic reactions to any vaccines or other injectable drugs. So again, it's always best to speak to your doctor, potentially about consulting an allergist. And then people who should not get these mRNA COVID vaccines, this is looking at the allergy portion in the red section, are those who have severe allergic reactions after a previous dose of one of these COVID vaccines or any of its components, or an immediate allergic reaction of any severity to a previous dose of one of these vaccines or any of its components. Or an immediate allergic reaction of any severity to a substance called polysorbate, which is potentially cross-reactive with some ingredients in the vaccine. So the other thing I want to point out is that for anyone who gets a shot, it is highly recommended that you hang around for a minimum 15 minutes at the site simply to be observed. So if you have a history of anaphylaxis, which is a severe form of allergy, and you fall into that green category of allergies, you need to hang around for 30 minutes. So be prepared to build in some time to hang out when you get the vaccine. So I want to just talk a little bit about the ingredients in the vaccine. So I mentioned that polysorbate. So you'll notice a list of ingredients here. This is a huge alphabet soup, I would think. But essentially, what the vaccines contain are that mRNA, which is genetic material, lipids, or a kind of a fat molecule, collection of molecules that help get the vaccine where it needs to go. And then chemical stabilizers listed at the bottom, which are salts, sugars, and buffers. The thing outlined, the verbiage outlined in blue, refers to polyethylene glycol that I mentioned earlier in individuals who, if they're allergic to it, should not get the vaccine. What is it? So it's typically an inactive ingredient in medications. It's actually the primary ingredient in osmotic laxatives and oral bowel preparations for colonoscopy procedures. It's used in procedures called pegylation, which improves the therapeutic activity of some medications. And it's generally inert, meaning it doesn't cause any type of response because it's fairly common in a lot of medications. Consequently, there have been very, very rare instances of potential allergic response to polyethylene glycol. Talk a little bit more about what to expect when you get a COVID vaccine. And again, this is pretty much sort of the lineup of when you're ready to get it. So before you receive the vaccine, kind of review the guidelines about whether it's recommended for you based on health history and and allergy history and some of the other things we talked about. Get as educated as you can, the CDC, and there are other websites that provide excellent information. When you are going to get your vaccine, wherever that might be, wear your mask. And after your shot, you should receive a verification card or printout that tells you the type of vaccine you received, the date you got it, and where you got it to help with preparing you to get your next dose. Finally, you should also get some information about the vaccine itself, whether in paper or electronic format. So after you have been vaccinated, again, you need 2 shots. We talked about the shot schedule in order for them to give you complete protection. There are apps out there to provide you with updates and other information. VSafe is a great one that's being offered by the CDC. Information there to download it is available on that slide. And then be prepared. You might have some side effects. I talked about a couple of them, which are simply normal signs that your body is building up protection or immunity. If you have concerning side effects, you certainly want to contact your healthcare provider. Okay, so I wanted to talk a little bit about the overall strategy or plan for the distribution of vaccines. I know this is an important topic right now. And remember, I had mentioned that vaccines started arriving into Virginia roughly 3.5 to 4 weeks ago. So I just want to start off by saying, the Virginia Department of Health is really committed to establishing equitable distribution of vaccine while the supply is still limited. We're waiting for supply to ramp up, all part of Operation Warp Speed, but we just have to understand supply is limited. Therefore, we're following prioritization guidance provided by the federal government and then further refined by the state of Virginia. So this pyramid broken up into its slices shows you the divisions of the population that have been broken up into several phases based on priority, starting with long-term care residents and healthcare personnel at the top. We're calling that tier at the very top of the pyramid 1A. So we then move on to tier 1B when we feel we've had a reasonable number of 1A vaccinated. And so this includes essential workers and individuals 75 years old and older. When we're kind of moving through that tier with momentum, we'll then move on to phase or tier 1C, which include other essential workers, certain age groups, and individuals with high-risk medical conditions before moving on to the general population. Now, the million-dollar question is, how long will all this take? And it's really a question of supply, as I mentioned earlier, as well as a question of capacity to vaccinate. So supply of vaccine is entirely dependent on vaccine company production. Capacity to vaccinate, or getting vaccine into arms, include all the places that can provide vaccinations, like pharmacies, doctors' offices, healthcare systems, and health departments. Now, getting all of those entities on board is ramping up quickly and is growing every day. So again, I want to reference that analogy I made earlier. We're fighting a battle and improving our offensive capabilities at the same time. So ultimately, you want there to be enough capacity and supply to be able to adequately suit demand. So therefore, it's really, really hard, as much as I would like to put a fixed date on when we'll get through each of these stages or phases. Though initial estimates, way back when, for being able to vaccinate the general public were roughly sometime in the spring or early summer. Don't hold me to that, that might change. So we've been in the 1A category. This is more looking a little bit more at detail in that the top of the pyramid I showed you earlier. We've been here in this part of the state, Chesterfield Health District, in the 1A category for around 3 weeks now. And we've been working to vaccinate healthcare personnel through the following means, through point of dispensing events, which are places where folks come and get vaccinated in large numbers. We've also been increasing the number of pharmacies and provider offices able to vaccinate healthcare professionals or personnel We've also been working with healthcare systems who have been striving hard to vaccinate their own staff and are interested in vaccinating other healthcare personnel. And so we're also working with local governments who are vaccinating their staff who fall into the 1A category. So there are multiple prongs to this strategy. So an important category listed in 1A are the residents and staff of long-term care facilities. So there's a federal partnership involving Walgreens and CVS who are sending their staff into long-term care facilities to vaccinate staff there, as well as that incredibly vulnerable population, an important population of residents in those facilities. Now that's something completely separate from what we are doing here at the health department. Now the final thing I want to mention is a press release went out today that my Metro Region Health Director colleagues and I felt that even though we weren't completed with 1A, and specifically the folks that we are reaching out to, these are the healthcare professionals or providers, personnel, a lot of P's there, we felt that there was enough movement being made to take baby steps into the 1B population. So as of Monday, January 18th, we're starting to open the doors for the following 3 1B groups to get vaccinated. And so this includes police, fire, and hazmat as a group, corrections and homeless shelter workers as a group, childcare and K through 12 teachers and K through 12 staff as a group. Again, I just want to repeat, there are so many factors regarding movement towards including other groups. Vaccine availability and capacity to vaccinate, again, are chief among them. So we continue to ask for your patience as we strive to get vaccines into arms. A lot of great people are working extremely hard to make this happen. We'll get there. I admit it's going to be a little bit messy at first, but we will get there. Kind of winding down, we're nearing the finish line with my presentation. So, of course, what's next? I think the question I'm getting a lot is, can we all toss away our masks and start hugging strangers once we've gotten our vaccination? I wish it was so. No, we'll have to continue those practices that we know work, partly because we simply don't have much data on how long these vaccines are effective, even though we have great data that these vaccines work well. The effectiveness of some vaccines wane or drop over time. This is experience that we've known with other vaccines. So we don't yet know about the COVID vaccine. Remember, I mentioned that phase 4 is ongoing, the phase 4 study of their effectiveness over time. So we're also waiting for better evidence about whether individuals who have been vaccinated are at any risk of even spreading COVID, even though they don't get sick with COVID. This is another factor that we simply don't have enough data about. The potential for asymptomatic, this is people who don't show symptoms, asymptomatic folks spreading even if you've been vaccinated. This just is testimony to how tricky this virus has been. So ultimately, when we get enough people vaccinated, and I've heard different estimates of this, say around 70% of the population, we hope we reach what is called herd immunity, which means that there are essentially enough vaccinated people who can't catch COVID that anyone who has it and is infectious, who has nowhere to spread it. So in other words, it's effectively snuffing out the flame before it spreads. That's essentially what herd immunity means. So I just wanted to offer up what I believe to be some really good resources to learn more for just general resources, as well as materials that have been created and drafted specific for various populations out there, many of which are listed on that slide. VDH has done a lot of groundwork on this, have conducted a number of different community conversations within those individuals listed, those communities listed, pardon me. You can find recordings and other information from those sessions. And there's also a lot of educational material out there. I think more is being generated all the time in different languages. Those are a few that are listed there. And finally, language, other language material from the CDC. So I hope this was helpful. That's, I think, a lot of ground covered in a relatively short period of time. I really, truly thank you for your interest in this important subject. Again, working very hard to be able to serve you and provide a vaccine in a timely manner.